Hello everyone, this is Priyadarshini, your mastermind faculty. I welcome you all to the NNL1, and today I welcome you all to the first and foremost session of your Friday Power Up under your Plan C Plus English edition. So this session is basically discussing about an important high yield topic followed by an MCQ analysis. So this series of session will be going to happening on every Friday under 5 to 7 p.m. so that you're going to learn a lot of things from me, and it is going to be a knowledge sharing sessions followed by the MCQ discussion you will be having in this. So today I am starting with my most favorite topic, that is heart block. So without any delay, let's get into the further session. So as you all know, heart block is one of the most important topic where the MCQs are mostly asked from this topic based on the ECG findings, based upon the causes, and based upon the nurse's responsibilities when the patient is on heart block and the medical management also. So here in this video, you're going to detailedly discuss about all the important NORCET centric and all the nursing competitive exam centric points under heart block with the ECG analysis, and followed by we will be going to the MCQ discussion. And Priya, Sia, Tommy, everyone, a very good evening. Okay, so first and foremost, as the picture and the GIF implies, what is heart block? As you all know, whenever we see the term heart block, we will be thinking that it is either any problem or any blockage in the coronary arteries which supply blood to our heart itself. But heart block is a term specifically coined in order to note that there is a problem in the electrical conduction system of the heart. Heart block is the problem in the electrical conduction system of the heart. Electrical conduction So basically you have to note, heart block is not any form of atherosclerotic plaque or anything like that, but it is a problem in the electricity of the heart. It is problem in the conduction system of the heart, where we have the basic structures which includes your SA node, AV node, bundle of S and Purkinje fibers. These are synchronized electrical rhythms which is happening inside the heart, which in turn produces the contraction and relaxation process. When there is a problem in this electrical impulse transmission, we term the condition as heart block. Okay, so before going into the actual component of heart block, it is very important for us to have a quick review on the anatomy and physiology of the electrical conduction system of the heart. As you all know, the primary pacemaker of your heart is your SA node. The most important structure and the primary pacemaker is your SA node, which is otherwise known as the natural pacemaker of the heart or the primary pacemaker. So the most important, another one point you have to notice, SA node conducts or purges the electricity at the rate of 60 to 100 beats per minute. 60 to 100 beats per minute. 60 to 100 beats per minute. Next, where it is situated, as the image implies, it is situated in your right atrium. It is situated in your right atrium. Then followed by the next and most important structure which we are going to discuss is your AV node. When we talk about your AV node is the second most important structure in the electrical conduction system of the heart, and it is situated in the right atrial border. Okay, right atrial lower border, to be more specific, lower border, and it produces the electrical impulses at the rate of 40 to 60 beats per minute, 40 to 60 beats per minute. And AV node is a very important point, because AV node is the one which makes a delay to give some time for the ventricles to fill. That is termed as AV nodal delay. And you have to note very important point, both SA node and AV node is situated in the atrium only, which means whenever the impulses are catched from the SA node and it is received at the AV node is the one part, one important component which is transmitting that impulses to the ventricles. Because until AV node, the impulses are only in the atrium. Your AV node is the only structure which is transmitting that impulses to your ventricles. And that AV node gives a small delay in conducting that impulses to the ventricles. That is termed as your AV nodal delay, which allows the ventricles to refill. Okay, which allows the ventricle to refill in order to eject the good amount of blood into your systemic circulation, right? So next is your AV node. So here, what about the conduction through your left atrium? So in the left atrium, we have some structure that is termed as your Buckman's bundle. That is known as your Buckman's bundle. Okay, this is situated in your left atrium, where the impulses is conducted to the left atrium as well. So from the AV node, the impulses are going into the bundle branches. This is termed as your bundle branches, or otherwise known as bundle of His. And to be more specific in exam point of view, this is your right bundle branch and this is your left bundle branch. Okay, so bundle of His is further innervated from the AV node and it is dividing into left bundle branch and right bundle branch. Next, we have the most innervating structures inside the ventricles. So which is giving the electrical impulses, powerful electrical impulses inside the ventricles. That is your what structure? That is your Purkinje fibers. That is your Purkinje fibers. So this is all about the basics of your cardiac conduction system. And the very important point is, even your bundle of His and Purkinje fibers have the ability to make some conduction beats, right? So here your Purkinje fibers can beat at the rate of 20 to 30 beats per minute. Okay, 20 to 30 beats per minute. When there is a failure of the SA node completely, in this cases your Purkinje fiber tries to put some electrical impulses in order to maintain the cardiac output. So that is the importance of your Purkinje fibers. When there is a complete delay or complete problem in the conduction system, at that time these Purkinje fibers will take the role and try to maintain the cardiac output by giving minimal amount of electricity inside the cardiac muscle. So that is the role of the Purkinje fibers. So this is how from the SA node to the AV node the electrical impulses are generated and it is transmitted all over the heart. Thereby the proper conduction is happening and proper contraction and relaxation is happening. So this is all about your basics of conduction system. And next we will get into the basics of ECG, so that you will be having the very important idea. So why we are going to see about ECG in heart blockers, the diagnosis of your ECG and the ECG patterns is mostly asked in your examination. So how we are diagnosing and what are the types? So these are all based upon the ECG findings. So it is very important for you to learn the basics of ECG. Then we will be getting inside the types of heart block. Okay, so first and foremost you have to know. So this is the basic ECG. So just ignore that image. Just concentrate on this image. So this is the basic ECG we have. This is your P wave, this is your QRS complex, and this is your T wave, and this is your U wave. Right? So what is this P wave is indicating? P wave is indicating your atrial depolarization, as you all know. Atrial depolarization, as you all know. Then your QRS complex is indicating Same ventricular depolarization, ventricular depolarization, and at last your T wave is indicating your ventricular repolarization. Okay, ventricular repolarization. So this is the basic of this. Yes, very good, Akshada. Your P wave is the atrial depolarization, your QRS complex is the ventricular depolarization, and the T wave is your ventricular repolarization. Depolarization means contraction, whereas repolarization means relaxation. Okay, so now the most important point you have to note in this ECG is the PR interval in case of your AV nodal block. So we will be seeing about all the intervals in all these segments so that you will be having a better clarity. So first you have to note what is PR interval. So what is PR interval? So the PR interval is calculated from where to where your PR interval is there means. So from the starting of your P wave to the starting of the QRS complex, starting of the Q, that is your PR interval. That is your PR interval. And you have to note the normal PR interval. What is the normal PR interval? The normal PR interval is 0.12 to 0.20 seconds. 0.12 to 0.20 seconds is the normal PR interval. Okay. So now, what is this PR interval indicating? PR interval is indicating the AV conduction timing. PR interval is indicating the AV conduction timing. AV conduction time. Please note all these important points. First you have to know what is the PR interval. Starting from the P wave to the starting of the Q is your PR interval. This PR interval, the normal value is 0.12 to 0.20 seconds. And what this PR interval is actually indicating? The PR interval is indicating the AV conduction timing, which means how much time I am taking to get the impulses from the SA node, the impulses which I receive from the SA node, how much time I'm doing it to transmit it to the ventricles, to conduct that impulses to the ventricles. That is the PR interval, right? So next, what are the other intervals which you have to note is your QT interval. So your QT interval is from your Q, from the starting of your, like I'll draw in another color so that it will be. So your QT interval is from the starting of your Q wave to the end of your T wave is termed as your QT interval. QT interval. So as you all know, what is the normal QT interval? It is 0.35. The normal QT interval is 0.35 to 0.43 seconds. 0.35 to 0.43 seconds. And what this QT interval is denoting, as you all know, it is very easy. It is your ventricular depolarization plus ventricular repolarization. Ventricular depolarization plus ventricular repolarization, right? So next, the most important intervals are your PR interval and the QT interval, and we also have the another important interval, that is the RR interval, that is for the next consecutive cycle. This R, when like for example here we are continuing with another cycle, so this is the RR interval. This is the RR interval. Okay, so this is very important point to note. After this, you have to learn about the segments. So the most important segments you have to learn is, first is your PR segment. There isn't always a misconception, like your PR interval is the AV nodal delay, but the actual point is your PR segment. Your PR segment, what is your PR segment? That is, your end of the P wave to the starting of the Q wave is the PR segment. This area is termed as your PR segment. Here you can see very clearly, this area is your PR segment. This area is your PR segment. So this PR segment is indicating your AV nodal delay. Very, very important point to know, exam point of view. This is very, very important point to note. So AV nodal delay is your PR segment. Your AV nodal delay indicates your PR segment. So very, very important point to note. So here we are going to calculate both in combination with the PR interval. So the under PR interval only your PR segment is also coming. So this PR interval value is very, very important to note for your ECG. So next we have seen the PR segment. Next we have then another important segment, that is your ST segment. So next we have the another important segment, that is our ST segment. So where is your ST segment starting? ST segment starts at the end of the S wave and to the starting of the T wave. This is your ST segment. This is your ST segment. This is your ST segment. So what is this ST segment is indicating? Anybody can tell me what is this ST segment is indicating? That is the plateau phase of your ventricular action potential. So ST segment indicates your plateau phase of your ventricular action potential. Ventricular action potential. So very, very important points to note. Each and everything will be asked in your examination. That's why I'm giving quite weightage to this area. So first we have seen about the PR segment. PR segment is the AV nodal delay. Next we have the ST segment. That is the plateau phase of the ventricular action potential. So the most important point you have to notice, see the diagram is quite it is quite irregular, but you have to note one point. All these structures, okay, all these structures in the ECG, especially you have to see ECG is going in the isoelectric line, as you all know. Consider this yellow line as the isoelectrical line. And you have to note, this is the PR segment and this is the ST segment. These both segments, PR segment as well as the ST segment are in the isoelectrical line, which means there will be no electrical conduction in these segments. When PR interval is the AV nodal delay, because I am giving some time for the ventricle to fill back. And ST segment is also an isoelectric line where there will be no conduction or no electricity. That's why it will be in the straight line and it will be coinciding with your isoelectrical line of your ECG. So this is your isoelectrical line of your ECG. See, you can see in this clear image, and this is your voltage as you all know, and this is the time as you all know, right? And the most important next point which you all have to note is your QRS. So in your QRS, the QRS duration is very important to note. Now tell me, what is the normal QRS duration? Any good student can tell me what is the normal QRS duration? The normal QRS duration is 0.10 to 0.12. The normal QRS duration is 0.10 to 0.12. As you all know, what the QRS is indicating? The QRS is indicating your ventricular depolarization. As you all know, the QRS is indicating your ventricular depolarization. And the normal QRS duration is very important. It is 0.10 to 0.12 second. And the another important thing you have to note in this QRS is, when the QRS duration is less than 0.10 second, it is termed as narrow QRS. And when the QRS duration is greater than 0.12 second, we term it as broad QRS. broad QRS. We term it as broad QRS. This is also very important point you have to note. Right? So this is all about your basics of ECG findings, and the other values which you can note here is specifically what is the P wave second. Here we have the specific P wave second, that is 0.18 to 0.111 seconds, and ST segments is less than 0.12, T wave is less than 0.20, and you all know, we have already seen the most important part which you have to note is the PR segment. Sorry, the PR interval. The PR interval value is 0.12 to 0.20 seconds. You should never ever forget this PR interval value while studying about your AV block. And to be very clear, so in spite, you all know the normal PR interval is 0.12 to 0.20 seconds. How to easily see in the ECG? How you will be, when you are seeing an ECG, how to easily find that this is the PR interval? Okay, how will you calculate that it is from 0.12 to 0.20 seconds? So you can remember in this way. So in case of you are seeing the small boxes, 3 to 5 small boxes, 3 to 5 small box is indicating one normal PR interval, or if you are taking the large box, one large box indicates the normal PR interval, which means you all know 1, 2, 3, 4, 5. So one large box is the combination of 1, 2, 3, 4, 1, 2, 3, 4, 5. 5 small boxes. And to be very specific, what is the calculation of timings? 0.04, and here it is 0.20. So one small box is 0.04. See, this is only one small box. Okay, and this one large box, the timing is 0.20 seconds. So in ECG, when you find the PR interval is more than a large box, or it is going more than 5 small boxes, you can see it is a prolongation of the PR interval. It is the prolongation of the PR interval. And we will have a quick review of this. First is, as you all know, this is the basic of ECG. We have P, Q, R, S, T and U wave. Right? So P wave, as you all know, P wave indicates the atrial depolarization, and the QRS complex indicates the ventricular depolarization, and the T wave indicates the ventricular repolarization. And followed by, we have the important intervals in the ECG. The first and foremost interval you have to note in AV nodal delay is the PR interval. As you all know, the normal PR interval is 0.12 to 0.20 seconds, and it is very important to note where the PR interval starts and where it ends. As I said, your PR interval starts at the PR interval starts at the P wave. Oh my god. Shit, how to go back? Sorry. So as you all know, let me draw the diagram again. Okay, I managed somehow. Okay, see, as you all know, where the PR interval starts. PR interval starts from the starting of the P wave and the end of the QRS. And the starting of the QRS. Start of the P wave to the start of the QRS complex. Start of the P wave to the start of the QRS complex. That is your PR interval. Next, we have the PR segment. The most important is the PR segment. So PR segment is it is calculated from the end of the P wave to the starting of the QRS complex, as we all have seen it and discussed it already. Next, the most important interval is the QT interval. The QT interval starts from the starting of the Q wave to the end of the T wave. That is your QT interval. As we already seen, the normal QT interval is 0.35 to 0.43 seconds. And next we have the ST segment. The ST segment is the end of the S to the starting of the T is your ST segment, and ST segment is very important in case of myocardial infarctions. As you all know, ST segment elevation is seen when there is a myocardial injury. See, you can note this also. It is a very, very important point. You can note. Just remember ST. Let me write here. So your ST segment elevation is seen in case of injury. On the other hand, the ST segment depression is seen in case of infraction. Myocardial injury, you can see ST segment elevation. When there is a myocardial infraction, there is ischemia, then you can see the ST segment depression, right? So that is how you have the basic detailing about your ECG, and very, very important point to note is your PR interval. As I said you, it is 0.12 to 0.20 seconds. So for additional information, what is U wave? If there is a question, what is U wave? U wave is your Purkinje fiber repolarization. Purkinje fiber repolarization is your U wave. Most of the time this U wave is not visible, so this is all about this. Next we will go to the next thing. So as I said you, heart block is the problem in the conduction system of the heart block. Heart block is problem in the conduction system of the heart. Conduction system of the heart. Anyway we can tell, like, the problem in the conduction of electrical impulses from one area to other area, or any delay in the conduction of electrical impulses, everything is termed as heart block. Never ever think about any other components other than electricity impulse in the heart block. So next, what is the causes of heart block? What is the causes of heart block? What is the cause of the heart block? Anybody can tell me what are the causes of heart block? Just tell me what are the causes of heart block. So the first and foremost is your myocardial infarction. Any kind of cardiomyopathy also leads to your heart block. So this in together can be termed as structural abnormalities. Next, certain drugs causes heart block. So drugs which causes heart block are, first is your digoxin, your calcium channel blockers, and your beta blockers. You people have to understand one thing, why these drugs are causing heart block. As I said you, heart block is the problem in the conduction system of the heart. So these three drugs, the major activity of three drugs is AV nodal block. The action of these drugs is AV nodal block. So already the problem is, I am not able to conduct the impulses from the AV node to the ventricles. So again, these drugs these drugs are already having the action of what? These drugs are already having the action of AV nodal block. So I will never ever give these drugs to my patient who is having heart block, right? So these drugs causes AV nodal block. That's why this is the causative factor of causing an heart block. And the most important next point you have to note, which electrolyte imbalance causes heart block. You should definitely remember this: hyperkalemia. That is, your increase in the potassium causes heart block. Increase in the potassium going to cause your heart block. As you all know, potassium is the intracellular electrolyte. when this intracellular electrolyte is moving extracellular, this is going to have an interaction with the resting membrane potential of your heart. There in turn, it is going to reduce the AV conduction and causing bradycardia. So that's why hyperkalemia will cause this heart block. And the other causes includes which includes your Lyme's disease, which is a tick-borne disease which causes calcification and lead to AV nodal block. And next is your Leaves disease. This is age-related conduction system fibrosis, sarcoidosis. These are the other causes of your heart block. Okay, so the causes of heart block is for structural abnormalities, which includes your myocardial infarction, cardiomyopathy, and drugs. Which are the drugs which causes heart block? First is digoxin, your calcium channel blockers, and your beta blockers. And which electrolyte is going to cause heart block? When there is a question, then it is hyperkalemia. Increase in potassium is going to cause your heart block, and followed by Lyme's disease, which is a tick-borne disease, that is your Borrelia burgdorferi, and your Leaves disease, which is an age-related degeneration of your conduction system, that is otherwise known as your Leaves disease. So these are the major causative factors of your heart block, right? So next we are going to see about the types of heart block. Till now you can be leisure, or you can be listening to the class so subtly, but now it is very, very important to put all your concentration towards this session, because this is the area where you will be getting the questions, right? So first, as you all know, we have three types of heart block. First is your first degree heart block. Next, it is your second degree heart block. Now tell me, anyone in the comment, second degree is further bifurcated into what? Now tell me in the comment box, second degree is further bifurcated into what are all the types? Second degree is bifurcated into second degree type 1, that is otherwise known as Mobitz type 1, or Wenckebach phenomena. So this is about the second degree type 1. Very good, Mobitz. Ruby, very good. It is type 1 and type 2. So next we have the type 2. In type 2 is otherwise known as you all know, there is no other name. It is otherwise called as Mobitz type 2. The most important point you have to note is first degree. Then the second degree is further bifurcated into two types, that is Mobitz type 1 and Mobitz type 2. Mobitz type 1 is the classification which is otherwise termed as Wenckebach phenomena. Next, at last, we have the third degree heart block, which is otherwise known as a complete heart block, Clear, children? A very, 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 very important point to note is that we have three types of heart block, that is first degree, second degree, and third degree. In that, second degree is further bifurcated into Mobitz type 1 and Mobitz type 2. Here, Mobitz type 1 is having another name, that is your Wenckebach phenomena. Now we are going to classically see what are all the ECG findings of these heart blocks, how the examiners will be putting a question on these sections. Right. So first and foremost, we are going to see about the first degree heart block. So what is the ECG findings of first degree heart block? Anyone in the comment box tell me what is the ECG findings of your first degree heart block. Yes, very good, Fatima. Stokes-Adams syndrome is seen in heart block, which is the classical sign of the heart block, which is a sudden syncope or a loss of consciousness seen without any prior symptoms. That is termed as your Stokes-Adams syndrome, which is seen in your complete heart block. Right? So we will see about the signs and symptoms after completing the types. So now coming back to the type 1 first degree heart block. Okay, sorry, first degree heart block. Now tell me, what is the classical ECG finding you will be seeing in first degree heart block? Now tell me, what is the classical finding you will be seeing in first degree heart block? So just note, in first degree heart block you will be seeing prolongation of the PR interval. Prolongation of the PR interval. Prolongation of the PR interval. As you all know, what is the normal PR interval? The normal PR interval is 0.12 to 0.20 seconds. So in this case, it will be greater than 0.20 seconds. It will be greater than 0.20 seconds, which means it will be more than 5 small boxes, in the ECG, or more than 1 large box in the ECG. Right? So the most important classical findings of first degree heart block is prolongation of the PR interval, which means you have to note, even though there is a prolongation of the PR interval, all the impulses which is generated from the SA node will definitely reach the ventricles. So what happened? The ECG cycle will be regular. Like each wave will be having a P, each cardiac cycle will be having a P wave, the QRS and the T wave, which means there will be a delay, but the impulses which is generated from the SA node, it will reach the AV node, and with a good amount of, I should not tell it is a good delay. So because of the condition, there will be a delay. Okay, there will be a delay, but it will be reaching the ventricles. Right, so that is the concept behind here, and you will not see any missed beats. Very good, Fatima. You will not see any missed beats in case of your first degree heart block, because whatever impulses is generated from the SA node is successfully reaching the ventricles, but there is a small delay in it. That is what we are terming it as first degree heart block. That is prolongation of the PR interval. So next we will see the ECG, so that you will be having a very good picture about it. As you see the ECG, I said you, this is your PR interval. As you people know, this is your P wave, this is your QRS, and this is your T wave. Right? As you all know, where is the PR interval starting? PR interval starts from your P wave and end at your Q wave. So here it is where starting, and here it is where it is ending. Right. Now tell me, as I said you, the normal PR interval is 0.12 to 0.20 seconds, and to be very easy to understand, it is not more than 3 to 5 boxes, that are small boxes, and not more than 1 box if it is a large box. Now we will calculate the large box so that it will be very visible for you. As you can see, here the half of the large box is there, and here one large box is there, and here again the half of the large box is there, which means the PR interval is greater than one large box, which is terming it as the prolongation of the PR interval. Prolongation of the PR interval more than 0.20 seconds. So we are confirming that the patient is on first degree heart block. Then you have to go to the second cycle. Again there is a prolongation of the PR interval. Okay. Again there is a prolongation of the PR interval, but the interval is very similar. That also you have to note, like it is going, it is delaying, but even it is reaching the ventricles. So that is what you have to note. No need to confuse yourself. There will be no drop in the QRS complex, because all the impulses which is generated are reaching the ventricles. That is the component over here that you have to understand. First degree heart block, the most important key term you have to remember is prolongation of the PR interval, which is going to be greater than 0.20 seconds. There will be no missed beats, right? So next we are going to the next thing. So let us solve this thing. What about the rhythm? The rhythm will be regular. Why the rhythm will be regular? Because every P wave is going to have its consecutive QRS complex and followed by the T wave, right? Next, what about the P wave? Yes, P wave is present. P wave is present. Next, we have the PR interval. The PR interval will be greater than 0.20 seconds. The PR interval will be greater than 20 seconds. What about the QRS complex? It will be in the normal morphology. The normal QRS complex is seen in this case, right? So this is all about your first degree AV block, right? So next we will go to the second degree. As I said, your second degree is further divided into Mobitz type 1 and Mobitz type 2. So Mobitz type 1 is what you are going to see now. What is the classical findings of Mobitz type 1? Anyone in the comment box, please tell me what is the classical findings of Mobitz type 1. Classical ECG findings of Mobitz type 1. Just remember this line. Just remember this line. It is progressive prolongation of the PR interval. Progressive prolongation of the PR interval. First degree we have seen it is prolongation of the PR interval, but in second degree you have to understand it is progressive prolongation of the PR interval. At first cycle, what the AV node is doing, I'm sending the impulses for you quite delayed. In the next time, what I'm telling, I'm so tired, I will do it even more delayed. In the next time, I'm very much tired, I'm going to send you even more delayed. If this delay and delay and delay, that is termed as progressive prolongation. When you see the ECG, it will be very clear for you. So you see here, this is the PR interval. Okay. For example, here it is 0.24 seconds. You remember. Next, this is an second cycle's PR interval. You can see this is around 0.30 seconds. In the next cycle you are going, it is even more longer. It is 0.35 seconds. 0.35 seconds. It's 0.35 seconds, right? So this is termed as your progressive prolongation of the PR interval. Just remember one thing, dear children, here, a very important point to note. As I said you, prolongation of the PR interval is different. Progressive prolongation of the PR interval is different. So in first cycle, I sent you the impulses quite delayed. In the second cycle, what I am doing, I am sending it even more delayed. In the third cycle, I am sending it even more delayed. So this is called as progressive prolongation of the PR interval. You can see the difference in the PR interval in the upcoming sessions. When this pattern you have seen, that is your second degree type 1, that is Mobitz type 1, or otherwise known as Wenckebach phenomena. When there is a progressive prolongation of the PR interval is seen, that is termed as your Wenckebach phenomena or the second degree type 1. Let's solve this. Now tell me, what about the rhythm? The rhythm is irregular. The rhythm is irregular. So you also have to note, like when this second degree type 1 is not treated, it will go to Mobitz type 2. So here where you can see there is no QRS complex, which means at last I become very tired and I am not at all conducting. AV node is telling I will not at all give any impulses to the ventricles. As I said you, AV node is a junction where it is transmitting the impulses from the atrium to the ventricles. So in this case, what happened? I am sending the impulses delayed and delayed and delayed. At last I am not at all sending. So that is the case here. At last, I am not at all sending. If at all AV node is not at all conducting impulses to the ventricles, ventricular contraction will not happen. Ventricular contraction is otherwise known as your ventricular depolarization. Ventricular depolarization is replicated, resembled in the ECG as the QRS complex. When there is no impulses, I am not sending anything to the ventricles, you cannot see ventricular contraction, so that you cannot see the QRS complex in the ECG. At last, there is a drop in the QRS in case of your Mobitz type 1. In case of your Mobitz type 1. So next we have, next we will solve this sheet. So what about the rhythm? The rhythm is irregular, as you all said. What about the P wave? P wave is present. What about the PR interval? PR interval, progressive prolongation. Very, very important point to note. It is progressive prolongation. Progressive prolongation. Next we have the QRS complex. The QRS complex is normal, but after progressive delay there will be the drop in QRS. There will be a drop in QRS. Drop in QRS. Don't confuse yourself. First is prolongation of the PR interval. Next is the progressive prolongation of the PR interval. Next we are going to see the Mobitz type 2. As I said you, in type 1 it is progressive prolongation, but in type 2 there is the important key point you have to notice. There is a regular PR interval, but there is a drop in the QRS complex. You have to note it. In second degree type 2 there is a regular PR interval. Regular PR interval, but there will be drop in QRS. Drop in QRS. Very, very, very important point to note. Drop in QRS. So as you see this ECG, the patient is having fixed PR intervals. Fixed PR intervals, but here for this P wave there is no QRS complex. Your QRS complex is missing, which means I'm trying to send it regular, but I cannot send it completely. So that is the concept behind here. And the very, very important point to note is Mobitz type 2 is the most dangerous and alarming kind of heart block, because this leads to your third degree heart block. This will further leads to your third degree heart block. So timely management of your Mobitz type 2 is very important. Most importantly, please note there is a regular PR interval, fixed PR interval, but I have a drop in the QRS complex. So how to differentiate? There you have seen progressive prolongation, but here you are seeing regular PR interval but drop in QRS. And one more classical thing which you have to note in type 2 is, here you have 3:1, 4:1 blocks. So what is 3:1 or 4:1 blocks? This 3 indicates, okay, this 3 indicates for every 3 P wave, there is 1 drop in the QRS complex. 1 drop in the QRS complex. For example, now tell me, now read this ECG, like what is this? What this is telling. So here, P wave 1, P wave 2, P wave 3, at last there is a drop in the QRS. So this is 3:1 block. So this is 3:1 block. When there is 4 P wave followed by its QRS complex and the 5th P wave is not having the QRS complex, we are terminating it as 4:1 block. So this is the concept behind this second degree type 2, right? So let's solve the cheat sheet, and here you can see the rhythm, as you all know, it is irregular. The rhythm, as you all know, it is irregular, because the rhythm is irregular because every P wave is not following its QRS complex. So that's why we are terming it as the rhythm is irregular. But next, what about the P wave? P wave is present, but there are more P waves than the QRS complex. As I said you, P wave will be there because SA node is conducting, but the AV node is the culprit here. That is not transmitting the impulses to the ventricles, right? right? So AV node is the junction, right, where it is transmitting the impulses from the SA node to the ventricles. So what happens? P wave is conducting properly because SA node is the one who is activating the P wave, atrial contraction. So P wave is there, but the QRS complex is absent. So when there is a consecutive block in the QRS complex, we are terming it as 3:1, 2:1 block. So this 3 is indicating the number of P waves, and for the number of P waves which has commenced properly with the QRS complex, there is a drop in the QRS complex. That is what indicating as 3:1 block or 4:1 block. Next, what about the PR interval? It is consistent. Very, very important to note. In second degree type 1, it is progressive prolongation, but in this case, in type 2, the PR interval is consistent, but the most important point you have to note is the drop in the QRS complex. The drop in the QRS complex. Some amount of impulses is not at all reaching the ventricles, so that the ventricular contraction is not at all happening. Next, what about the QRS complex? Here also the QRS complex is going to have the normal duration. As I said you, the normal duration is 0.10 to 0.12 seconds. When it is greater than that, we are terming it as broader QRX. So in some cases, the QRS complex can be broader when the conduction delay is very bad. Okay. So next. So this is the quick picture recap for you to understand the 3 types in so clearly. So this is the first degree. As you all know, there is a prolongation of the PR interval. The first degree, this is the prolongation of the PR interval. You can see there is a consistent prolongation of the PR interval. This is the consistent prolongation of the PR interval. So this is the second degree type 1. In second degree type 1, what you can see, there is a progressive prolongation of the PR interval. This is small, I am bigger than you, I am even more bigger than you. So this is called as the progressive prolongation of the PR interval. Next we have the second degree type 2, that is your Mobitz type 2. Here what happens, I have regular PR interval, but there is a drop in the QRS complex. Right? So next we will go to the third degree heart block. The important key term which you have to note in third degree heart block is, third degree heart block indicates no association between the P wave and the QRS. There is no association between the P wave and the QRS. So what happened, as I said you initially while studying about the anatomy and physiology, if there is a complete failure of SA node, AV node and everything, what is happening? Purkinje fibers start to purge its own electricity so that it can maintain a minimal amount of cardiac output to support the systemic organs. Right. So what happens in third degree heart block is, I am not at all receiving any impulses from SA node and AV node. So what I am doing? I am going to start my own impulses. I am going to generate my own impulses. The life-saving impulses that is transmitted by the Purkinje fibers is termed as your third degree heart block. Which means there will be no connection between the SA node, AV node and the Purkinje fibers. SA node will purge in its own direction. Purkinje fibers will start its acceleration in its own direction. So there will be no association. In a proper ECG, the P wave should be followed by its QRS complex and then the T wave. In case of third degree heart block, P wave will be in one side, QRS complex will be one side. You can see 2 QRS, 2 P waves, like that. The pattern will be so irregular. That is termed as, there is no association between the P wave and the QRS complex, is termed as your third degree heart block, which is otherwise known as your complete heart block. The other thing you have to notice, narrow complex escape rhythm. What is meant by escape rhythm is, when I am trying to save the heart, save the cardiac output, when it is generating its own impulses, that is termed as escape rhythm. When actually it has to come from the SA node, but to save the life of the patient, when the Purkinje fiber is activating its impulses or the bundle of his is activating its impulses, this is termed as escape rhythm. This is termed as escape rhythm. So this narrow complex escape rhythm, where the QRS complex duration will be less than 0.12 seconds, that originate above the bifurcation of the bundle of his. This happens above the bundle of his bifurcation. Next we have the broad complex escape rhythm. This happens when there is greater than 0.12 seconds. The QRS complex is going to be greater than 12 seconds, and it originates below the bifurcation of the bundle of his. When there is a question like narrow complex escape rhythm is arise from, it is above the bifurcation of the bundle of his. When they are asking about the broad complex escape rhythm, your answer should be below the bifurcation of the bifurcation of the bundle of his. Okay? Yes. So ECG findings. As I said you, the rhythm is variable. We cannot tell it is regular or irregular. The rhythm is like, it is completely irregular, which means there is no association between the P wave and the QRS complex. So what about the P wave? Present, but it is not associated with QRS complex. SA node is activated one side and your Purkinje fibers is activated one side, AV node is activated one side. So there will be no regular pattern at all. That is what we are terming it as QRS. There is no association between the P wave and the QRS complex. Next we have the PR interval. Obviously when the P wave is following the QRS complex, only you are going to have a PR interval. When there is no association, you cannot see any kind of PR interval there. Next, what about the QRS complex? As I said you, based upon the narrow complex and broad complex, you will be having escape rhythms. So next we are going to see the clinical manifestations. First is your clinical manifestations of your heart block. Clinical manifestations of heart block. The first and foremost important, this is the question point, important signs and symptom of heart block is bradycardia. Bradycardia. So the next is syncope, which is otherwise known as, classically known as Adams stroke attack. What is Adams stroke attack? As I said you, what is Adams stroke attack? Adams stroke attack is the sudden loss of consciousness by the patient without having any kind of period symptoms. So next is hypotension, then dizziness. So these are the important signs and symptoms of the heart block. Hypotension, also you can see fall in the systolic BP. Fall in the systolic BP. Fall in the systolic BP. Now let's we go to the management of heart block. So now tell me, what is the management of heart block? Now tell me, what is the management of heart block? Please answer me the management of heart block. Anyone? So what is the management of first degree, second degree and third degree? First degree, second degree and third degree. In first degree, most of all, no, there will be no chest pain. There will be no chest pain, Akshada. There will be no chest pain. There will be bradycardia, hypotension also, a fall in the systolic blood pressure followed by syncope. In this, classically the syncope is termed as your stroke Adams attack. So these are the classical features of your heart block. So next we have the management. So first degree patients, always, you know, you have learnt it, it is a prolongation of the PR interval. So first degree patients, mostly they will be asymptomatic. So what is the management? What is the nursing management? We will just observe the patient. We will just observe the patient. Next, in second degree, in type 1, the patient will be exhibiting some symptoms. When the patient is exhibiting some symptoms of bradycardia, hypotension, but the patient is hemodynamically stable. So in this case, what we are going to do? Yes, it is atropine. The most important point you have to note, what is the drug of choice in case of your heart block? If you get an MCQ, your first and foremost priority, you have to close your eyes and you have to go and take atropine. Right? When the patient is symptomatic, you're going to go for atropine. But the patient is stable, hemodynamically stable, but he is possessing minimal symptoms. In that case, we are going to administer atropine for that particular patient. So the most important point you have to note is, we have under autonomic nervous system, we have sympathetic and parasympathetic, right? Sympathetic and parasympathetic. Now, anyone in the comment box, please tell me, sympathetic will do what effect in the heart rate and parasympathetic will do what effect in the heart? Just remember, sympathetic will increase the heart rate, whereas your parasympathetic will decrease the heart rate. And that too, you people have to note, this is an additional information which I am giving you. Like, sympathetic nervous system will increase the heart rate, but it decreases the other components. Other vital parameters will be decreased in case of your sympathetic activity. Whereas your parasympathetic nervous system decreases the heart rate but increases the other components. Right? So it is very, very important to note, your sympathetic nervous system is increasing the heart rate, your parasympathetic nervous system is decreasing the heart rate. So as you all know, your atropine, what is the action of atropine? Atropine is your parasympatholytic. It is your parasympatholytic drug. Parasympatholytic drug, which means, to be very specific, it is a muscarinic antagonist. Muscarinic antagonist. So what happened? It suppresses the parasympathetic activity so that it promotes the heart block. Sorry, it promotes the heart rate, which means it promotes the heart rate. Very good, Akshada. Sympathetic increases the heart rate and parasympathetic reduces the heart rate. Very good, very good, very good. So here you have to note, your atropine is a parasympatholytic drug. Mimetic drug means which is promoting the action. Lytic drug means which is inhibiting the action. Right? It is a parasympatholytic drug. So otherwise we can term it as your muscarinic antagonist drug. So what it is doing, it is going to promote your heart rate, which means it is going to, this atropine, what it will do, it will be working on the conduction system, it will be stimulating the AV node to produce more impulses and it is going to increase the heart rate. So now the most important, again the important point you have to note here is, what is the dosage of atropine? The dosage of atropine is 0.5 mg. Okay, you are going to give 0.5 mg for every 3 to 5 minutes. For every 3 to 5 minutes, you are going to give 0.5 mg. And the most important, another one exam specific point is, what is the maximum dose of atropine you can give? A very common question, it is only 3 mg. So with an interval of 3 to 5 minutes, 0.5 mg, 0.5 mg, 0.5 mg and I am giving, and maximal 3 mg I can give, and then I will conclude. Now we are coming back to the second degree type 2. As I said you, second degree type 2 is the most dangerous and it is leading to the second degree heart block. As I said you, it is leading to the third degree heart block, that is your complete heart block. In this case, the important management, here the patient will be possessing more symptoms and he will be in the stage of chronic bradycardia. So in this stages he is in the case of acute bradycardia, but here in the second degree type 2, Okay, here in second degree type 2, the patient will be in the chronic bradycardia. So in this case, the most, Fatima, very good, it is 3 mg, atropine maximum dose you have to give 3 mg only, and you have to give in the interval of 3 to 5 minutes, 0.5 mg, 0.5 mg, 0.5 mg, like that you have to give it for every 3 to 5 minutes, and maximum you have to give only 3 mg. So the most dangerous is your second degree type 2, as I said you, which is going to lead to your complete heart block. Yes, very good. Akshada, like second degree type 2 is always treated with your pacemaker. So initially, to stabilize the patient, we can go for transcutaneous pacing, transcutaneous and transvenous, and then if the patient is not at all reverting, we will be going for permanent pacemaker. At last, we have the complete heart block. In complete heart block, there is no other way, the patient is going for permanent pacemaker. Permanent pacemaker. Permanent pacemaker. Right? So now, let's go to the next slide. So, this is quite advanced only, but I thought it will be possibly asked in your examination, so I have put this. So first is single chamber. So in pacemaker mode, we have single chamber. What does mean by single chamber? The pacemaker electrode will be placed in the atria only. The pacemaker electrode will be placed in the atria only. Okay. So it paces the atrium and senses the atrial activity. What does mean by it paces the atrium and senses the atrial activity means? So here there is a failure. So what I am doing, the electrode is placed inside the atria and it will be transmitting the impulses. It will be doing the work of SA node. But additionally, what does mean by sensing? And there is a word of sensing, which means I am not just like that delivering the impulses. The electrodes of the pacemaker is not just like that delivering the impulses, but I am sensing the activity of the cardiac muscle as well, which means it is sensing, it is giving a minimal concentration towards the cardiac muscle also. If it is spending and if it is sending an adequate thing, the pacemaker will be working quite suppressively. Right, that is called as sensing. So this indicated in case of sinus node dysfunction. Sinus node dysfunction is termed as your what? SA node dysfunction. So the most important thing or additional thing which you have to note here is so as I said you, this is indicated in case of SA node dysfunction. SA node dysfunction is otherwise known as SA node dysfunction. What is the condition? Anybody in the chat box? It is sick sinus syndrome. Sick sinus syndrome. In this case, he will be having the similar findings of heart block, but there will be absent of P wave. There will be absent of P wave. There will be absent of P wave. Sick sinus syndrome is the syndrome of dysfunction of your SA node. In this, the patient will be exhibiting similar clinical manifestations of heart block, but the patient will be having, the ECG will be having the loss of P wave. There will be no P wave. So in this case only we are going to give this atrial pacing. Right? In this case only we are going to give the atrial pacing. So ECG features, what the ECG features, as the single chamber atrial pacemaker is pacing at the atria, so that you can definitely see the pacing spikes before the P wave. Pacing spikes before the P wave. Right. So monitor for loss of AV conduction. So you have to monitor the AV conduction is happening properly or not. Next you have the single chamber ventricular only pacer. So here it will be same like the action of atria. The electrode will be only in the ventricle and paces the ventricle, ignores the atrial activity. Here no sensing of the atrial or ventricular impulses is seen, and this is administered in case of complete heart block and chronic atrial fibrillation with bradycardia. So the pacing spikes, you can see it is in the QRS complex. Atria, P wave. When it is in the ventricle, it is in the QRS complex. So here you have to note this ventricular pacemaker, single chamber ventricular pacemaker, will lead to pacemaker syndrome. What is meant by pacemaker syndrome? We have seen about 6 sinus syndrome. Now we are going to see about pacemaker syndrome. What is pacemaker syndrome? Whenever there is an asynchrony between the ventricular and atrial contractions, we term it as pacemaker syndrome. This happens for patients with pacemaker, and ventricles and atrial contraction will not be having a proper synchronization. That is termed as your pacemaker syndrome. Right. So next we have dual chamber. In dual chamber, both atria and ventricle will be having electrodes in each of the parts, and coordinated AV timing, pacing and sensing will be happening, because both electrodes are monitoring and administering the electrical impulses. Here the sensing will be also done in both atria and ventricles, and the pacing will be also done in both atria and the ventricles. So this is advised in case of AV block, sinus node dysfunction and 6 sinus conditions. So the spike will be seen, definitely both are there. So P wave and the QRS complex, both will be having the spike in the ECG. I will be showing the image so that you will be easily understanding. So best preserving the AV synchrony, that is otherwise termed as your pacemaker syndrome. Okay. So next we have biventricular pacemaker mode, which means it will be having the pacer in the right atrium and both the ventricles, right and left ventricles. It resynchronizes both ventricles, which means it works by in combination of electrical generation between the both ventricles, and this is administered in case of heart failure, low left bundle branch block, and when the patient is having the low ejection fraction less than 35%. So triple pacing spikes you can see because you are having 3 spikes, which means you are conducting the atria and you are conducting both the ventricles. So you can see 2 spikes in front of the QRS complex. So rate responsive pacer. So rate responsive pacer, what is meant by rate responsive pacer means, so the pacemaker will sense the conduction system of the patient. Based upon it, it will be acting. So like if the pacer senses as of now 60 beats per minute is going so regularly, so it will be acting subtle. It will not generate, it will not put any additional pacers. So that is called as rate responsive pacemakers. When the rate is reducing, it will start pacing its electricity. That is called as rate responsive pacemaker. Adjust rate based upon the activity and metabolic needs of the patient. For example, if the patient is doing exercise, it will sense it and it will pace accordingly. If the patient is subtle, it will be monitoring it and it will be pacing according to it. So sinus node dysfunction, bradyarrhythmias with activity limitations will be administered with rate responsive. Here ECG features, the rate will be increased in exertion, because I said you, based upon the activity of the patient, the rate will be sensed and it will be increasing. Next we have temporary pacemaker, depends upon the lead placement. Short-term pacing support is either administered transcutaneously or transvenously. So implantable cardioverter defibrillator, this is the permanent pacemaker. This senses arrhythmias and even gives shock. That is the implanted cardioverter defibrillators. This senses, this implantable cardioverter defibrillator, what it will do, it senses the arrhythmias, it senses the irregular rhythm, and it will provide shock when it is a shockable rhythm. So secondary prevention of sudden cardiac death and pacing plus shock spikes in the arrhythmia can be seen in the, and must educate to avoid magnets and follow up care. So next, you can be asked with image based MCQs, that's why I have put this. Just a minute. Water. Sorry for the interruption. So now you can see this is the image of the permanent pacemaker. This is the image of the permanent pacemaker. Okay, and this is the image of your temporary pacemaker, that is your transcutaneous pacer in the left side, you can see. So you can be asked with image based questions also. So kindly note, This is your permanent pacemaker, and this is your temporary pacemaker. So this is inserted under your clavicle. This is administered transvenously. Okay, most probably if you see in coronary care units, you can see this transvenous pacing hanging in the IV sets, or sometime it is placed next to the patient also. So here very important monitoring is done by the nurses. So it is very important to know the nursing responsibilities, which we are going to see now. So intra-procedural monitoring as by the nurses for transvenous pacing is, so first, as you all know, the main thing is we have to maintain. So we have to maintain the sterile field. You have to monitor the ECG and blood pressure, basic things. Prepare for transcutaneous pacing if needed, and check the pacemaker settings before and during the procedure. Everything, the rate, the rhythm, the pacer, the sensing, everything is set period when the pacemaker is administered. So next, post-procedure. If it is a permanent pacemaker, what we are doing is, again, monitoring the ECG continuously so that you can see the ECG spikes. I will show you the image. Check for the signs of complications at the site. Hematoma, bleeding, infection, and pneumothorax most commonly can happen. Monitor the insertion site for bleeding or swelling. Either for permanent or for transvenous pacing, you have to monitor it. For example, if the patient is on transvenous pacing, okay, if the patient is on transvenous pacing, okay, if the patient is on transvenous pacing, so what you have to do, you have to limit the movement. For example, in the right femoral, the patient is inserted with the transvenous pacer. Okay, so what happened? You have to limit the movements for 48 hours. Because you should not disturb anything which causes any kind of dislodgement or misplacement. So it is very important, you have to limit the movements of the lower limb. If it is a femoral, if it is inserted femorally, the transvenous pacing is done. You have to limit the movement of your lower limb for 48 hours. This may be asked as a question also, so kindly note. So in case of permanent pacing, so here we go. In case of permanent pacing, so keep the affected arm immobilized or restrained, example sling, for 24 hours. When the pacemaker is inserted below the clavicle, the permanent pacemaker, here the restriction of movement should be there in the left arm. That is what we are telling, like the immobilization should be there. We should not give more action or mobility towards this particular side. This comes under the important nursing management of the post-procedural permanent pacemaker patients. Right. So avoid arm elevation greater than 90 degree for at least 1 to 2 weeks. We are not going to move the arms. This is 90 degree. We are not going to move the arms more than 90 degree for 1 to 2 weeks when the patient is in the permanent pace, after the implantation of the permanent pacemaker. Very important point to note, because this causes any misplacement or any dislodgement of the electrodes. So that why is to set it properly, we are doing all this management. Immobilization is very important. So next we have the complication monitoring. So failure to pace, absence of pacing spikes. As I said you, as we were seeing, either it is a transcutaneous, either it is a transvenous, either it is a permanent pacemaker, the first and foremost thing which we are doing is ECG monitoring. The ECG of a normal patient and the ECG of the patient with pacemaker is very different, because you can see the spikes. If it is a single chamber in the atria, you can see the spikes before the P wave. If it is a single chamber in the ventricle, you can see in the ventricle, like before the QRS complex, you can see the spike. So that spikes also you have to monitor, which means the pacemaker is working efficiently. So if there is bradycardia also, you can understand that the pacemaker is having quite dysfunction. So next, failure to capture spikes without QRS, which means pacemaker is generating the electricity, but it is not conducted by the heart. It is not conducted by the heart. That is the failure to capture. Failure to sense spikes during normal beats, which means, as I said you, what is meant by sensing? Failure to sensing, I said you that if the pacemaker is sensing, For example, my heart now it is moving normal, like sorry, not moving normal, it is conducting normal, it is giving 60 beats per minute. But even if it is giving 60 beats per minute, the pacemaker is not sensing it properly, and it is again giving more paces or more electricity. That is the failure of sense. In this case, what you can see, spikes during normal beat, the patient is on normal beat, but we are giving additional paces, that is indicated in the form of spikes. Next, monitor for pacemaker syndrome. What is meant by pacemaker syndrome? As I said you, when there is an asynchrony between your ventricular and atrial contraction, that is termed as your pacemaker syndrome. So these are the symptoms of pacemaker syndrome: dizziness, hypotension, and the syncope. Right? Yes. So patient teaching, a very important slide, a very important question slide for MSc students or whatever. Am I properly audible now? Just give me the comment. Am I properly audible now? Please check your networks when you are not able to capture it properly. So avoid lifting arm above the shoulder for 7 to 14 days. As I said you, we should not go more than 90 days when the patient is having permanent pacemaker implanted. No MRI unless pacer is safe. MRI safe. Very important point. Now with advanced technology, MRI safe pacemakers are coming. But when the patient is having a pacemaker, he will be carrying his own band that he is having a pacemaker, and he will be not exposed to excessive electromagnetic areas. Right? So MRI, very important consideration. Even a nurse will be there in the MRI also. She has to assess these things. Basic details has to be collected from the patient. Next, avoid strong electromagnetic fields, high voltage wires, large magnets, arc welders. So these and all, the patient should not be get exposed to these areas because it can cause some reaction. So carry pacemaker ID card always, so that people will be knowing he is a patient with implanted pacemaker. Check pulse daily, report if less than the set rate. Educate the battery life. So nowadays with advanced battery lives, the pacemakers are coming, but you have to give instruction about the battery life of the patient. Maximum 10 years it is coming. Right? So next is, yes, this is the important slide again. Please note it down. So as I said you, there will be spikes. So this is atrial spike, as you see before the ECG. This is the normal ECG. Whenever you come to MCQ, there will be always lot of confusions. That's why you need a very clear practice before going for examination. So identify the ECG, what is the most appropriate nursing intervention. Here they are asking you to identify the ECG, and then you have to come up with a conclusion. What is the management of this? Okay. Now tell me, as per the findings, we will check whether it is first degree or not. First degree is prolongation of the PR interval. Yes, it is greater than 1 large box. Yes, prolongation of PR interval is there. Prolongation of PR interval is there. Now tell me what is the answer. Prolongation of the PR interval is there. Whether all the PR interval is regular? Yes, all the PR intervals are regular, and there is no drop in the QRS complex. So we are concluding this ECG is the first degree heart block. First degree heart block. So what is the management of first degree heart block? Now tell me what is the correct answer. Prepare for emergency transcutaneous pacing. No, first degree heart block is not needed. Administer atropine. This is the management of second degree. Continuous monitoring and withholding AV nodal blockers. Yes, continuous monitoring of the patients is necessary. The patient should be put in the observation, and any kind of AV nodal blockers, which includes your digoxin, calcium channel blockers, and your beta blockers, should not be administered for patients with prolongation of the PR interval. Right? Very good. Fatima, you are correct. C is the correct answer. Start dopamine infusion immediately. No, that is not that much serious. So next we are going to the next question. Interpret the ECG. Now we are going to interpret the ECG. Yes, we are having here a very short PR interval, followed by an long PR interval and an even more long PR interval, and the drop in the QRS complex as well. But even though there is a drop in the QRS complex, AV block is permanent pacemaker implantation is mandatory due to its risk of sudden progression to complete heart block. This I have discussed. Now tell me what is the answer. So in which type of AV block is permanent? What is the answer? Your form of dangerous type in your heart block. Your form of dangerous type in your heart block, which will lead to your complete heart block. This needs a permanent pacemaker. First degree AV block doesn't need a permanent pacemaker, any permanent pacemaker, but Mobitz type 2 is a type which will be leading to complete heart block, so we are going for permanent pacemaker. Now tell me, a patient with chest pain shows complete dissociation between P wave and QR. I'm just waiting for the answer. Even QRS complex. As the question tells, there is a no association between the P wave and the QRS complex and the heart rate. Patient is in severe bradycardia, which is completely indicating the patient is in third degree heart block. So what patient will go to second degree type 2 heart block. Please remember this. So next question. A patient with Mobitz type 2 heart block suddenly becomes unresponsive. The patient with Mobitz type 2 heart block suddenly becomes unresponsive. What should be the first nursing action? Administer oxygen. Yes, it is important, but not a primary. Call the code blue and begin the chest compression. When you are talking, Mobitz type 2 is again a severe form of bradycardia, as you all know, children. When the patient is suddenly becoming unresponsive, what does unresponsiveness means? There is poor perfusion. What is meant by poor perfusion? Myocardial ischemia, and there is no proper circulation to the systemic organs. So what happened when the patient is going for unresponsiveness, which means it is poor perfusion, and the patient is going for cardiac arrest. Analyze the question properly. That is what you need. Whenever you read the content, you cannot get the actual core concept which you have, but you have to practice MCQs. Very, very important point. See, listen, the patient is already a case of Mobitz type 2 and he is becoming unresponsive, which means he went to loss of consciousness. So in this case, what will happen? It indicates it is poor perfusion and the patient is going for cardiac arrest. You are not going to administer atropine at the time. The primary nursing priority action will be activating code blue and starting the chest compression in order to promote the perfusion. Right? So please note this down. It is not atropine. It is not nothing. Atropine, first and foremost, it is type 2, children. It is type 2. I said atropine will be administered only in Mobitz type 1. Mobitz type 1, when the patient is stable, hemodynamically stable. Here the patient is going unresponsive, which means is going hemodynamically unstable. At that time, atropine is not going to work. Right, you have to learn this. It is very important. CPR is the one which is going to save the patient at this point of time. Right, I hope it is very clear. When it is type 2, atropine is not the thing. Second degree type 1, you are going to give atropine when the patient is hemodynamically stable. But in case if the patient is hemodynamically unstable and he is going to type 2, when the patient is becoming unresponsive, which means he is becoming hemodynamically unstable, so you are going to start the chest compression and save the patient. So next, so a patient with Mobitz type 1 AV block reports dizziness and lightheadedness. So now just, what is the nurse initial priority? Now tell me, the patient is a case of type 1. Now I think you can answer so easily. the patient is a case of type 1 and he reports dizziness and lightheadedness. He is having minimal symptoms. What is the nurse priority action? Start IV dopamine? No. This we will go in very severe cases. Monitor and document rhythm. This is not going to help you out. Administer atropine. As I said you, in type 1 AV block, administration of atropine we are going to do in order to reduce the parasympathetic activity, because your atropine is a parasympatholytic drug. So reassure the patient and check the blood sugars. Totally irrelevant to the question. So C is the correct answer, and very congratulations to all the students who have answered correct. Akshada, Shashmita, Fatima, Madhavalam, Niharika, very good. So let's go to the next question. A patient receiving digoxin, as we discussed earlier, digoxin is one of the causative factor for heart block and develops bradycardia, and ECG shows second degree AV block. They haven't mentioned which type, but they have mentioned second degree AV block and the patient is taken digoxin. What is the first nursing action? Now tell me. Digoxin is a AV nodal blocker. The action of digoxin is AV node blockage. So again, the patient has developed a bradycardia and the ECG is showing second degree AV block. And the most important thing I am going to additionally tell you is, whenever the patient is taking digoxin, the high risk is second degree AV block. And in second degree AV block also, the most common the patient get is Mobitz type 2. Note this, students. Mobitz type 2 is common in patients with digoxin toxicity as well as post-MI patients. So what is the first nursing action? Now tell me. Increase the dose of digoxin. Very good, Shashmita. Very good, Shubham. Very good, very good, very good. So increase the dose of digoxin. No. Already the patient is going for bradycardia. Digoxin is going to cause further bradycardia. So next we will go to the next question. Now match the following question. Yes. So just now, what is the answer? It is progressive prolongation of the PR interval with the drop in the QRS complex. Then the drop. But there is regular. Mobitz type 2. Fixed heart block, as you all know. No relation between the P wave. For 2, the answer is the classical definition of Mobitz, your P wave and the QRS complex. You can there is an interruption. When you have any doubts, you can ask it in this particular Instagram page. It will be answered effectively. All the very best for all the nursing aspirants who is preparing for all the competitive examination related to nursing. Have a nice day. Bye.